My name is Dr. Simon Mattison. I'm one of the consultant anaesthetists here at Harefield Hospital. I wanted to provide you with some information which will help you prepare for your upcoming heart surgery. When you first arrive in our theatre department, you will come into our reception area where I am standing now. Here you will be met by one of our theatre staff who will check you in and go through our initial safety checklist, which is a sequence of questions, some of which you will have been asked before, but all of which are important to allow us to look after you safely whilst you are under our care. After the reception area, you will be brought into one of our anaesthetic rooms. This is a small room next door to one of the operating theatres. Most of what happens to you from this point onwards will happen to you asleep, so you will not be aware of it. But there are a few things that we have to do first in order to safely get you off to sleep. This includes the usual monitoring that people get when they come into hospital, such as the sticky ECG dots on your chest and also the peg that sits on your finger to monitor your pulse and oxygen levels. We also have to pop a small drip into one of your veins, and we also insert what is called an arterial line. This is a drip that goes into the back of your wrist here where you can feel the pulse, and this allows us to monitor your blood pressure very closely, both as you go off to sleep and during the subsequent operation. Once we have done all that, we give you the medicines that send you off to sleep, and that is the last you will be aware of anything until your operation is all finished. There are, however, a few more additional components that we need to do as part of the anaesthetic after you go to sleep but before the operation starts. These include a breathing tube that goes down your throat, which we connect to one of our ventilators. We also have to put a special type of drip in the side of your neck. This is called a central line and is a standard feature for all patients undergoing heart surgery. We also have to put a catheter in your bladder to monitor your kidney function. And finally, we put what's called a TOE, or an echo probe, down your gullet. This is similar to when they put the cold jelly on your chest and do the ultrasound of your heart. We do a version from the inside during the operation. This gives us lots of useful real-time information about how your heart is functioning, and also allows us to look at any new valves that may have been implanted during your surgery. Once we have done all that, we take you into the operating room and allow the surgeon to proceed with your operation. At the end of your operation, you will be brought to intensive care. That's normal for everybody having heart surgery and isn't anything to worry about. When you first arrive here, you will still be asleep. That's deliberate on our part. We keep everybody asleep for a period of time after their surgery in order to monitor you very closely and make sure that everything is as we expect it to be. Once we're happy, we switch off the drugs that are keeping you asleep, and you gradually start to wake up and start to breathe for yourself. Once you are awake enough and breathing adequately, we take out your breathing tube and just give you a normal oxygen mask and let you breathe for yourself. The period of time that you will be asleep for depends a little bit on how complicated your operation is. If the operation is straightforward, we would expect to wake you up around 2 hours after the end of your surgery. If your anaesthetist thinks that there is a possibility that you will be asleep or in intensive care for longer than this, they will discuss the details of this with you when they meet you. Whilst you are in intensive care, you will have a nurse with you all the time. That's a standard feature of intensive care. Every patient has their own nurse. So any problems at all, such as pain or sickness, you just ask them and they will be able to help you with it. For pain specifically, you will have a system called a PCA. This is essentially an electronic pump. The pump is connected to one of your drips, and it also has a button attached to it. This button will be in your hand when you wake up, and whenever you press the button, you will receive a dose of painkiller automatically from the pump. The important thing to know about it is the pump is programmed so that you cannot overdose. So you can press the button safely without any anxiety that you are doing yourself any harm. If you are still in pain despite pressing your button regularly, just tell the nurse and there are other things that we can give you to help as well. All things being equal, most patients spend one night in intensive care. By the next morning, we get you out of bed, sitting in a chair, offer you some breakfast, and try and encourage you back onto the path of normality and recovery as quickly as possible. Some patients who are having more complicated surgery may need to spend longer in intensive care, as I previously mentioned, and if we are expecting this to be the case, as I have said, we will talk to you in a bit more detail about this when we meet you. Once you are well enough to leave intensive care, you will go to what's called our high dependency unit, which is one level down from intensive care, usually again for 24 hours, although of course this can vary a bit from person to person, and then a few days back on our normal surgical ward until you are well enough or strong enough to go home.